Good morning, everyone. Hello, and welcome to our Making Digital Health Real series. This fortnightly series aims to provide a space to discuss emerging research, share career insights, showcase projects and networks for those interested in digital health. I'll just start today's webinar with acknowledgement of country, and then I'll hand over to Portia. So before we begin, I would like to acknowledge and pay respect to the traditional owners of the lands upon which we're situated today, which is the lands of the Wurundjeri people of the Kulin Nation, and pay my respect to elders past, present and emerging. We acknowledge that sovereignty was never ceded, and we also extend this respect to all traditional owners of the lands from which you're participating on today. I'll now pass over to Dr. Portia Cornell, who's a Senior Research Fellow in the Digital Health Innovation Team. Thanks, Portia.
Thanks, Christy. Some of you may remember me from presentation on economic evaluation, but today it is my honor to introduce you to my colleague from Brown University, who's joining us all the way from North America, Dr. Emily Gadbois. She's a health services researcher and gerontologist. She's an assistant professor of health services policy and practice at Brown University. Her research examines how interorganizational policies and practices impact outcomes and experiences for older adults. She's primarily a qualitative researcher, and she's led numerous projects exploring healthcare for older adults, and she also teaches a graduate seminar in qualitative research methods for health services. So, Emily, thank you so much for joining us, and I can't wait to hear about the project you'll tell us about today.
Yeah, thank you so much, Portia. And thank you for inviting me to be a part of the Making Digital Health Real series. I'm just so appreciative of the opportunity. Just one quick thing, I would love to take questions, but I'm I think unable to probably see things that come up in the chat, but Portia has graciously agreed to monitor the chat. So please feel free to drop questions in there. I think clarifying questions, Portia's planning on interrupting me, which I'm very excited about, but can also hoping to have time at the end for more substantive discussion with all of you. So thanks so much. All right, so excited today to speak with you about a pilot intervention that I led a few years ago, and sort of share findings from that, share next steps, and get your thoughts and ideas. All right, sorry, a little bit of a lag here. Okay, traditional presentation format, no surprises there. All right, so some background. So social isolation and loneliness among older adults are critical public health concerns associated with cognitive decline, and comorbid conditions, depression, suicidal ideation, and mortality. And in addition to these health impacts, isolation and loneliness are also associated with greater healthcare utilization and spending among older adults. And so given these, extremely substantial negative outcomes, healthcare providers and payers are increasingly focused on designing and delivering programs to reduce loneliness and isolation. And research is increasingly committed to understanding all of these relationships among social connection, loneliness, isolation, and outcomes for older adults. Homebound older adults, who in the US currently make up about 13% of people 70 or older living in the community. And this is a number that's been increasing in recent years due to the pandemic, and I understand is similarly increasing in Australia, are at increased risk of isolation and loneliness due to mobility limitations caused by chronic illness, cognitive decline, and injury. And so while traditional therapeutic approaches and services have demonstrated some success in reducing isolation and loneliness for older adults, these programs are most often delivered in community-based settings, and so they typically are not reaching homebound populations who may have unique barriers to access. So a potential strategy to reach these homebound older adults is through information and communication technology, or ICT. ICT has been found to be an effective means for older adults to maintain contact with their existing social networks and also to build new relationships. However, limited financial resources, lack of accessible technology support, and technology illiteracy limit the adoption of ICT among older adults, especially those who are homebound. And so these barriers require approaches that are tailored to homebound older adults who have significant potential to benefit from ICT strategies to reduce isolation and loneliness. All right, so to that end, we conducted a novel pilot intervention that we called Talking Tech. This intervention was designed to reduce loneliness and social isolation among homebound older adults by providing one-on-one in-home technology training to promote digital literacy and participation in a virtual senior center. Okay, so basics of the intervention. Talking Tech was embedded within and delivered by a home delivered meals program. We chose this setting because we have a longstanding relationship with Meals on Wheels America, which is the largest membership organization of home delivered meals programs in the US. And Meals on Wheels programs are sort of uniquely positioned to reach homebound older adults. And so our intervention provided training and assistance to participants using trained volunteers that we called TechMates over a 14-week period in 2020. This training and the support focused on how to use a tablet, access the internet, and participate in a virtual senior center program, which was called Well Connected. Well Connected is a free national phone and internet-based program which provides dozens of sessions each week that people can participate in, and it's got topics like virtual travel, support and conversation groups, bingo, language learning. And so to try to get people to participate in this virtual senior center, participants were paired with this volunteer TechMate, and they were given a tablet and a hotspot internet connection for 1 year if they didn't already have the internet in their homes. And so while the intervention lasted just 14 weeks, participants kept the tablet and were also able to continue to engage with their volunteer TechMate and with the program staff at the Meals on Wheels program. Although we only provided the internet free for 1 year, the home delivered meal program also engaged with interested people to explore possible options to maintain internet if that's something that they wanted after that year was up. And then structure of the intervention. So during the first 4 weeks of the intervention, participants received one-on-one in-home training on how to use the tablet, how to access the internet, and how to join well-connected programming from their assigned volunteer TechMate. And so at each visit, the TechMate delivered a training module that was expected to last 1.5 hours to 2 hours. And in each visit, they, so overall, the TechMate had this binder that included the module objectives, instructions, program materials, handouts, etc. So that was the first 4 weeks in participants' homes, one-on-one training. And then during the following 8 weeks, the TechMates called the participants at a time that they mutually agreed upon. So they'd schedule in advance, okay, I'm going to call you and we'll stay on the phone, you know, for this half hour once a week, and we'll talk through, you know, what challenges you've had that week, you know, what you'd like to work on that week. And then during the final 2 weeks, it was sort of an as-needed basis. The participant was encouraged to call the TechMate if they needed any help. As I mentioned, there were the sort of prepared modules, but we really tried to promote individualization. And so TechMates were encouraged to try to determine and respond to participants' personal goals regarding technology as well. Okay, so recruitment. Intervention participants were recruited from within the local home delivered meals program. So participants were eligible if they received meals from the program, they were 60 or older, and they were homebound or had difficulty leaving their homes independently, which is a requirement to receive meals from the program. we had to try several recruitment methods. So initially, the meal delivery drivers suggested clients that they thought were likely to be isolated or lonely. And so program staff then called those individuals that were identified that way. But unfortunately, that didn't yield too many signups. So after that, they sent a flyer to basically everyone. They gave out the flyer as part of the meal delivery. And they also, at the same time, used responses from an annual client survey. So in this survey, clients were asked if the services that they received from the meal provider helped them to feel less lonely. And then they reached out to people who indicated that the meal program either didn't help their loneliness or who commented about being lonely in an open response area. And so using a combination of these methods, 21 participants were recruited. As we'll talk about a little bit later, a challenge of working with a community-based organization who provides services is that, ideally, an intervention would be as pragmatic as possible and not create additional, too much additional burden for participants. And so unfortunately, we weren't able to get a real breakdown of how many people were recruited with each of these methods. Okay, recruitment of techmates. So program staff also identified and recruited techmates. So here, eligibility criteria included self-identification as computer and internet literate and interested in working with older adults one-on-one in their homes. So techmates were first recruited from the existing pool of 700 meal delivery drivers in the program. Unfortunately, this wasn't hugely successful. And we think in part that's because many of those meal delivery drivers are older adults themselves and maybe perhaps less confident in their technological capabilities. So we also leveraged contacts with corporate partnerships that the meal program had and recruited volunteers at a local university. And ultimately, we had 18 volunteers who served as techmates, and 3 volunteers signed up to work with 2 participants each. Techmate training. So we engaged with a technology training company, which trained the techmates in a 1-hour, one-time session. Volunteers were given a manual that contained the program goals, expectations for techmates and participants, lesson plans for each module, participant worksheets, and a Well-Connected, which is the virtual senior center brochure that included a schedule of all of their classes. There were also instructional handouts on setting up the tablet and appropriate shortcuts, setting up the hotspot, and accessing Well-Connected. The training was offered in person and by video recording, and 16 volunteers attended the in-person training and 2 viewed the recorded training. This slide shows a figure of the data that we collected to evaluate the intervention, which I'll be going into in more detail in the next slides. Okay, so we use several methods to evaluate our pilot intervention. These included in-depth semi-structured interviews with participants, with volunteer techmates, and with the program staff. And those interviews were designed to examine program adoption and acceptability, in addition to the impact of the intervention on participant well-being. We also gathered weekly reports from the techmates and conducted quantitative baseline and follow-up surveys to measure the impact on well-being. And then we also collected some performance metrics. So for those qualitative interviews, on completion of the intervention, we conducted interviews with participants, techmates, and program staff. The participant interviews included questions about tablet and Well-Connected accessibility and usability, the use of Well-Connected, the perceived impact of having the internet and Well-Connected on use of on loneliness and other aspects of well-being, and also their satisfaction with the techmate training and Well-Connected sessions. We also asked questions about the impact of the pandemic, as this was something that started sort of midway through this intervention. Staff and techmate interviews explored implementation experiences, facilitators and barriers to program delivery, and suggestions for improvement. So TechMate reports, during the first 4 weeks of the intervention, which were those in-home one-on-one sessions. Well, they were all one-on-one sessions, but the first 4 weeks were the in-home ones. TechMate submitted a report to the program coordinator after they completed each session with the participant. And these reports had places and prompts about the duration of that interaction, any questions that the participant asked, participant comfort level and interest with the tablet and Well Connected, challenges and ideas for improvement. And what was really great about these reports was that it allowed us to sort of catch any problems as they were happening and then allow us to try to course correct. Okay, so participants also completed surveys at baseline and at week 15, which was 1 week after the final session, to assess changes over time. These surveys included validated scales used to measure well-being, perceived isolation, loneliness, technology use, and demographics. And lastly were the performance metrics, which included client participation in the 4 in-home training sessions, which we tracked through the use of those TechMate reports and also through the participant interviews. And then we tracked well-connected use by working with their parent company. And that included the hours that participants engaged in well-connected sessions and which sessions they participated in. All right, shifting to results. So 21 people were recruited and received a baseline survey. The mean age of the participants was 73. Sample included 13 female and 8 male participants, 12 identified as white, 6 as Black, 2 as Native American, and 1 as Hispanic. Many were widowed, had completed high school or higher education, and lived alone. And most did not own a computer, smartphone, or tablet prior to the start of the intervention. Of the 21 participants who completed the baseline survey and officially enrolled in the program, 18 ultimately completed the intervention and were reached for the follow-up survey and interview. Of those 3 who were not reached, 1 withdrew during the 2nd week of the intervention due to a lack of interest. 1 entered a skilled nursing facility, and another was lost to follow-up for reasons we don't know. Of note, these 3 participants did not appear different at baseline from those who did complete the follow-up survey and interview. And then for 4 of the 18 participants who did complete the follow-up and interview, COVID affected intervention delivery such that the first 4 training sessions, which were designed to be delivered in participants' homes, were shifted to telephone sessions. Okay, so in terms of adoption, 10 participants ultimately accessed well-connected sessions by the time of the follow-up survey and interview. These 10 participants took part in between 1 and 7 sessions each, and the sessions that they attended included virtual travel, conversation groups, museum tours, entertainment and music, health condition support groups, games, and reading and writing groups. Regarding the acceptability of the intervention, so we received TechMate reports. Those were those weekly reports that TechMates were providing those first 4 weeks. We received those for 16 participants, and nearly all participants reported having a positive experience with Talking Tech. These TechMate reports indicated that people were very interested in the program and excited to learn how to use the tablet. And in a few slides, I'll be giving a lot more detail, including example quotes from those TechMate reports and also from interviews. Okay, so looking at sort of the quantitative impact of the intervention. So baseline, we compared the baseline pre-intervention survey data with the post-intervention follow-up data. Across participants, there were no significant differences for any of the measures between baseline and follow-up. Loneliness scores, however, were trending in the right direction, with a mean score of 6 at baseline, reducing to 5.44 on the follow-up survey. So here, a score of 6 is the sort of official cutoff indicating loneliness. So 6 or higher indicates loneliness, lower than 6, according to this validated scale, this indicates that they're not lonely. So there were, however, differences in loneliness within participants. So from baseline to follow-up, 9 individuals were less lonely at follow-up. And for 2 of those participants, their scores changed from being lonely to not lonely, according to that cutoff. 1 participant did have a higher loneliness score from baseline to follow-up, and 8 participants stayed the same. All right, social isolation. So while 6 participants had scores that indicated they were less socially isolated from baseline to follow-up, 8 participants were more isolated and 4 stayed the same. Now here, it's really important to note that I am so glad we had a qualitative component of our evaluation, because if we were just relying on these quant measures, we would not have been able to show very much value from this intervention. And the qualitative component also allows us to understand potential reasons for these quantitative findings. But before we talk about those qual findings, there was a trend toward increases in technology use from baseline to follow-up. 7 participants reported greater use of the internet for activities including shopping, managing prescriptions, social media, other health-related activities, while 3 reported less use and 8 stayed the same with their technology use. All right, so now for some of those qualitative findings. As I mentioned, a strength of the qual is that it really allowed us to understand perhaps why our intervention was not as successful as we hoped, beyond the obvious reason that loneliness and social isolation might be high during the pandemic. Most of the participants received their baseline survey prior to March of 2020 and their follow-up after March of 2020. So it certainly would make sense that isolation and loneliness would not necessarily be improving during that time. But so areas for potential improvement were identified during these post-intervention interviews. A few participants in TechMeet suggested including more training sessions to accommodate participants with a slower learning pace, or those starting with more limited technology knowledge. One such participant reported a desire for more assistance, saying, "Once I'm online and once I do it several times, I think I can learn how to do it, but I would need somebody working more of a full-time basis to assist me." Alternatively, others with more computer experience described that some of the aspects of the module content were too basic. Several participants also found Well-Connected confusing or had difficulty navigating the online platform to access classes. As was described by this TechMate on this slide, my participant was so good at using the tablet. She knew how to do everything. Then as soon as we got to Well-Connected, it was like all the skills went out the window. I just couldn't get through to her to use it. Additionally, some participants encountered registration and scheduling issues with Well-Connected that led to challenges with participation. Explicitly, while participants were provided with links to Well-Connected's online brochures and schedules, participants were also given and relied heavily on paper printouts of the schedule. So then when there had to be modifications to that schedule, they weren't aware because they were relying on that printout. So while participants were able to join Well-Connected sessions, this person commented that they didn't get into the online ones because all the times were screwed up. As I've been indicating throughout, the pandemic proved a challenge. For 4 participants, COVID prevented them from completing their in-home training sessions. This inability to complete the training sessions in person was associated with a reported lack of ability to use the technology. One such participant described a desire for additional training sessions that went beyond the basics of using the tablet and helped them get more comfortable on the internet. They said, "What I hoped for is somebody to help me learn more than how to use the laptop online and all that. I know I can probably do it, but I have to have somebody to help me. I think I only had 3 sessions with her." Despite these disruptions in lessons due to the pandemic, participants viewed the program positively and reported that technology intervention really could be helpful to benefit older adults. As one participant stated, "It's just bad timing, but the program itself, I think, was a great idea. Really, I don't know how I got this lucky." So consistent with that sentiment, participants and TechMates reported a number of benefits that they reported receiving from Talking Tech, including several ways that Talking Tech helped to reduce loneliness and social isolation. First of these was that participants noted that the support and weekly visits that they received from their TechMate made them feel less lonely. Speaking of their TechMate, one participant said, "She came for 4 sessions and then we had so much fun, so I was really appreciative. My first impression was just so perfect." Another participant described the social benefit of their connection with their TechMate, saying, "She was so kind. We hit it off right away. She's my friend, my young friend. She's like my granddaughter." Another primary social benefit was that learning how to use a tablet and access the internet allowed participants to reconnect with friends and family. One participant described her appreciation for being able to connect via email, saying, "It does help with giving me a purpose and helping me stay in contact with people. I haven't had email in years." Participants also reported using video conferencing platforms to stay connected. "The best part of the program is now I don't get to talk to my family out of town much, so to find out what they're doing, I mean, I can see them and they can see me." Another participant said, "I've got friends in California, older friends that we talk on the tablet. I talk to my son in Maine on the tablet." In addition to the reported benefits of the connection to the TechMates and the 2 existing networks, most participants also described that Well-Connected was a tool that they thought could help decrease feelings of loneliness, or they reported feeling less lonely themselves because of Well-Connected. For example, one participant said, "It knocked me right out of my loneliness. Just hearing a voice of education gave me a little hope." Another participant discussed joining sessions on hearing loss and becoming part of a community, saying, "One was on hearing. I have hearing problems. I got 2 hearing aids and it was all about that. People talking about how they have difficulty, which helped me understand my problem. It was a little hard at first, but then it's like once you talk to them for a little bit, all of a sudden it's like you've known them for years." As you might imagine, in addition to the social benefits, another primary benefit was receiving the tablet itself. As was reported by this first TechMate, "You just had to see participant's face when I gave her the tablet and informed her that it was hers to keep. It was like Christmas morning." Receiving a free tablet was also, described as a primary benefit of the program, with participants describing it as a source of life and opening up another world. Another reported benefit was really that participants enjoyed learning. One participant highlighted the value of lifelong learning, saying, "I mean, what's better than learning? Do we stop growing because we hit a certain age? It shouldn't be that way." Other participants noted how easily the program fit into their current routines. One such participant described the value of the virtual travel and museum sessions that they had taken part in, and said, "Well, it takes you out of your bedroom into another country. It takes your mind off your loneliness, but it also opens up, if you can't travel, I call it bedside travel. The museums, that's totally my favorite. I just love art, I love history, and I love museums, which I never loved any time else in my life. All of a sudden, I have this newfound desire to learn." Lastly, regarding benefits, participants use their tablets and the internet for a variety of purposes. As one TechMate said, he's confident using the internet to read news articles, get recipes, and watch news videos. Another TechMate reported that their participant was interested in using the tablet and the internet for educational purposes, saying she was watching a television program the other day on polar bears and melting ice and wanted to know more about that, but didn't know how. I told her how to Google that, and that she should see a slew of articles on the subject come up. Her eyes lit up. Okay, so overall, these findings are consistent with the prior literature, which has demonstrated the value of information and communication technology for facilitating social connection among older adults. Our findings do, however, extend that prior literature, demonstrating that with tailored approaches, ICT may be an effective tool to increase socialization, specifically among people who are homebound. This point about different uses for technology bears further investigation, as prior research has found that older adults, while using technology for social purposes has been found to be associated with decreased loneliness, the use of technology for entertainment purposes is associated with increased loneliness. So future research is really needed to explicitly focus on which aspects of technology use and which types of use are best able to meet the diverse needs of older adults. The findings regarding TechMate volunteers. So we found that this connection with the TechMates was really something beneficial. Participants really got a lot out of these relationships. So, this was not intended to be part of the intervention, the relationship with the TechMate themselves. So, we should try to investigate further, to try to disentangle what really was, most beneficial. It's also worth noting that these relationships have been found in prior literature to be reciprocal, such that like volunteers report getting a lot of benefit from participating, from volunteerism, and from connecting. Okay, so the state of the research on effective interventions for loneliness and social isolation in older adults is really still pretty preliminary, and there are critical gaps in understanding how interventions may be applied to the community setting and to the homebound older adult population. And so this evidence gap makes translating research into practice rather difficult, and these challenges were really further exacerbated by the pandemic. In response to the pandemic, service providers really had increased urgency to develop and deliver solutions to reduce loneliness and isolation among older adults. And these community-based organizations have really prioritized ICT solutions, but many of these services and their adaptations to a remote or virtual format have yet to be studied. And so the pandemic, I think, really underscores the need for research and practice partnerships to translate evidence on isolation and loneliness into practice. Let's see. So regarding resources, so our pilot was designed to be implemented both one-on-one, in person, and then to shift to telephone calls after completion of the in-person sessions. Our results indicated that while this approach helped many of our participants gain technology skills and connect to new and existing networks, for some, especially those who had less technology experience to begin with, and for those whose participation was impacted by the pandemic, remote training was really not sufficient. So organizations that are thinking about implementing programs like these really need to weigh considerations that those with the least technology experience and the resources to support engaging via technology might be the same people who have the greatest need for social connection. And so in order to avoid excluding those with the highest need, greater resources may be needed. All right, limitations. So although our sample was really pretty diverse for a tiny pilot study involving older adults, obviously replication and expansion are needed in order to determine whether these benefits that participants reported might be found more broadly. Such future research might also benefit from the feedback from participants and TechMates about the need for greater individualization of the training. The pandemic was also another limitation, as the mode of intervention delivery had to be modified from in-person to telephone, which made the already pretty difficult task of teaching and learning new technology skills additionally challenging. And then another limitation, of course, is the pre-post study design. The use of a control group in a quasi-experimental study might help to address exogenous factors like the COVID pandemic moving forward. Despite these limitations, strengths of the pilot include the low loss to follow-up rate, and really the value of the partnership with our the community-based organization that delivered this. The success of participant retention is really likely due to the existing relationship and the trust between the participants and that delivering program, which highlights the importance of engaging community-based organizations in research and leveraging existing resources and relationships. Successful participant and techmate retention, I think, suggests that this intervention is feasible and acceptable, and a larger study could better examine the potential efficacy of the intervention to reduce loneliness and social isolation in a randomized controlled trial. However, we did not decide to do that sort of randomized controlled trial next. As I think I've alluded to, this intervention was really pretty labor intensive for the community partners. We did pay the community partners for their carrying out of this project, but it was really very labor intensive. So we sort of, instead of doing that next step of expanding this particular study, we actually ended up taking a bit of a step back and wanted to understand instead what they were already doing, which we thought could help facilitate a more pragmatic intervention. So next we conducted a strictly qualitative study to explore a few common types of socialization programming that these home delivered meals programs were already offering. So these included a telephone reassurance program where there are regular phone calls between volunteers and clients. It also included friendly visitor programs where there are regular in-home visits. And last was wellness activities, which were either virtual or in-center wellness activities, and include like sort of a range of different activities, from bingo to yoga to, art kind of classes, to gardening, all sorts of things. And so we conducted interviews with 117 volunteers, clients, and staff across 6 different programs, and have been really trying to understand what goes well about those programs, what doesn't go so well, with the goal of informing sort of next steps in designing something more pragmatic. We're currently working on publishing those findings, but regarding digital health, our findings are really centering on the importance of sort of hybrid socialization offerings, especially in light of the pandemic. We are finding that hybrid programs are really useful, not just during times of outbreak, but also in cases where there's bad weather. People are also reporting that the increased sort of flexibility offered by hybrid socialization programming is very appealing. And hybrid options are also particularly good for people who are homebound. Of course, we're also hearing quite a lot about the challenges of using hybrid or technology-based solutions. And these are primarily the high cost, limited technology knowledge and confidence among older adults, and then also access to technology itself and to the internet, especially in more rural areas. Okay. And so I think I flew through that, but that brings me to questions, and maybe I'll stop sharing my screen.